Okay, well, good evening, everybody here from the UK. Thanks very much for joining us for the Journal of Hand Surgery European Volume Official Journal Club. So this is the only place where you will get to hear from the authors of papers at the journal, the perspective of expert clinicians reading those papers, and get inside the mind of the handling editor who actually tackled the manuscript, took it through its processes. So if you're interested in all those perspectives, this is the only place to get it. And tonight we've got two great papers. We're really pleased to welcome the authors, Philippe Bellemere and Ahmed Sadek. Philippe talking about his review article on pyrocarbon arthroplasty, and Ahmed talking about his observational studies of flexor tendon repair. And they will be cross-examined with questions from Jill Arrowsmith from the Pulvertaft in Derby, and Daniel Heron, the Secretary General of FESSH, joining us from Zurich. And we're extremely grateful to welcome the editor-in-chief himself in China. He's had to get up in the middle of the night to join us especially for this. We're extremely grateful for that. And we're going to be hearing summaries of these papers tonight by Soha Sajid and Yazan Al-Ajam, two of our hand fellows. And we're also just really grateful to the team that put this together at the BSSH and the digital media team, because they put a lot of effort behind the scenes for this. So thank you for joining us. I hope you have a great evening. And we're going to start with Philippe Bellemere's pyrocarbon arthroplasty review. So I'm going to hand over to Soha to present that. Thanks.
Sorry, just try and get.
Thank you. Good evening, everyone. I am Philippe Bellemere from Nantes. I am orthopedic surgeon and hand surgeon. At the head of the Institut Lamain of Surgery of the Hand, with I have 8 colleagues. Very happy to be here and to get my paper presented in this meeting. Thank you to the FESSH, to the BSSH, and to the Journal of Surgery Hand Club.
Okay. Thank you. Good evening, my name is Soha Sajid and I am a fellow at the Pulvertaft Hand Centre in Derby. I've been asked to present the paper Medium and Long-Term Outcomes for Hand and Wrist Pyrocarbon Implants, written by Philippe Bellemere at the Institut de la Mains Nantes Atlantique in France. Pyrocarbon implants have now been around for over 40 years, and they can be categorized into either non-constraint hemi or total arthroplasties or spacers. This paper is a review of 8 implants with a combined experience of 8 surgeons at this centre since 2002. The first implants discussed are the PIP joint and MCP joint. So for the PIP joint, the author comments that the implants had a very high operation rate due to implant migration, and therefore they are no longer performed. For the MCP joints, the happy spacer implant is used. Indications for it include osteoarthritis, both primary and post-traumatic, as well as selected cases of rheumatoid arthritis. The technique involves the resection of the metacarpal head distal to the collateral ligaments, followed by manual reaming of the head to create a concave surface for the implant. The results are not yet published. For thumb CMT and STT joints, the main message is to avoid shortening of the thumb column and thus limiting weakness and thumb MCP joint hyperextension. For trapezium replacements, the Pi2 and Pyrodisc implants have been discussed. The Pi2 implant is a 9mm epsiloidal implant which is stabilized with an APL and FCR ligamentoplasty. The Pyrodisc implant is a donut-shaped implant which allows a Gore-Tex suture to run through the implant and around the FCR tendon to stabilize it. Robust stabilization is key to avoid dislocation, and therefore these implants are not recommended in severe Z deformity. The mid to long-term results show a low pain score, a quick dash score of 20, and no thumb hyperextension. There were no implant revisions reported in this series, and there was a 4% dislocation, but this did not cause any clinical consequences. The author also uses a pyrocarbon implant in early stages of osteoarthritis, mainly Eaton 1 and 2. However, this is not recommended in subluxation. This is a rectangular shaped implant with 2 concave surfaces. It requires less resection of bone, and therefore no ligamentoplasty is required. It also needs careful preservation of the soft tissues too. The results show for 27 patients with a mean follow-up time of 17 months, the quick dash score was 10, the grip was 94%, and the pinch was 98% compared to the contralateral side. For a longer follow-up of 62 patients followed up for a mean time of 5 years, the pain score was minimal, the quick dash score was 7, and the grip and pinch were equal. There were 2 patients in this group that required revision. For the STT and pantrapezial joint, the Scaphotropisial pyrocarbon implants have been used. This implant is a concave implant is a implant with a concave surface which faces the scaphoid and a convex surface which faces the trapezium. It requires resection of 3 to 4 millimeters of scaphoid. The author now uses the pyrocarbon implant. This has 2 concave surfaces and is rectangular in shape, and therefore affords better stability with better maintenance of the thumb height column, of the thumb column height, and of thumb kinematics. The results for 22 patients followed up for a total of 36 months showed an average functional recovery time of 7.2 and an excellent satisfaction score. There was no implant instability. For cases of pantrapezial osteoarthritis, the author recommended a double interface or Berger arthroplasty with pyrocarbon implants either side. Careful preservation of bone vascularity and avoidance of extensive soft tissue dissection were strongly recommended. However, no results have been given. Moving on to the wrist implants, the adaptive proximal scaphoid implant has been used. This implant replaces the proximal scaphoid, creating a radioscaphoid arthroplasty. It is recommended in avascular necrosis as well as early stages of osteoarthritis to prevent further collapse. However, it is not recommended in a marked dizzy deformity. The technique involves a radial approach with radial stylodectomy if required, if there's osteoarthritic changes present. The proximal scaphoid is resected and the surface is milled to allow for implantation. No further ligamentoplasty is required. The results for 33 patients with stage 1 snack wrists with a mean follow-up of 10 years showed a range of movement of 101 degrees, a VAS pain score of 1.2 and a wrist strength of 86%. There was excellent satisfaction reported, and the Meyer wrist score was 80 with a PRWE of 18. There were 2 implant dislocations reported, but this did not, only 2 of which required reoperation. The author also noticed that there was some remodeling of the capitate head in many of the patients. However, this did not cause any clinical issues. For the radiocarpal arthroplasty, the Amandis implant has been used. This acts as a free spacer interposition arthroplasty. Indications include osteoarthritis, again, both primary and post-traumatic, as well as rheumatoid arthritis. It can also be used in failed wrist surgery as a salvage procedure. For the implant to be used, it requires preservation of the anatomical alignment of the wrist, as well as the periarticular tissues. The technique involves a dorsal approach, an L-shaped capsulotomy, and the triquetrum is preserved along with the intercarpal and midcarpal ligaments. There's also careful preservation of the periarticular tissues, particularly the palmar capsule. This is vital for stability. Results of 200 patients showed that the revision rate for the implant was 6%. A more detailed follow-up of 51 patients over 5 years showed a grip strength of 68%, a range of movements of 75. The quick dash was 34, an improvement from preoperatively, and a VAS score was 2.3, again, an improvement from preoperatively. There was no subsidence reported over time. So overall, this is a very well-written and very interesting comprehensive review of pyrocarbon implants written by a very, very experienced surgeon. However, it is only a single center study, and although most of the results are published, not all of them are. The results report cohorts of patients only, and there's no comparison with controls or other techniques. What would be very interesting would be to have survival curves and an implant registry like we do for hip and knee arthroplasty. Of note, the author also declares that he is a consultant for Wright Medical Tornio, who manufacture the implant. I will now hand over to the panel for further discussion.
Thanks very much, Soha. That was a really great summary of what's a phenomenal review in terms of just the sheer detail and volume conveying Dr. Bellemere's tremendous experience. Just to say for the audience, I know there's over 100 of you watching tonight, fire up questions you have using the Q&A function, but we're going to go to our experts now. So I'm going to bring in Jill Arrowsmith, please.
Thanks very much, Jeremy. Thank you, Soha, for the presentation and Philippe for the paper. I've got a first question for both Philippe and Daniel, because you're both very experienced with PIP joint pyrocarbon implants, but I note from the paper that you've stopped doing them, Philippe, and I wondered why that was. Why don't they work in the PIP joints?
Thank you for your question, and thank you to Soha for her presentation. For the PIP joint with pyrocarbon in my hand, it doesn't work very well, but it may work. And in my opinion, there is two reasons for that. The first reason is because pyrocarbon has no osteointegration. So if you want to fix a prosthesis into a shaft of centromedullary bone, it's not possible. There is no osteointegration, so you may to fix your prosthesis with press fit, and it's very difficult to do that. The second reason is because this prosthesis, PIP pyrocarbon prosthesis, is not modular. And if you want to have a correct matching of the two components of the prosthesis, you may prepare very well the two anatomical centromedullary cavity, and there are in individual very big differences between first phalanx and middle phalanx. And so there is a lot of mismatching. So it's very difficult to get a very good matching of the two components. And if you try to get it, maybe you can break your implant, or if you have a loose prosthesis, you will have instability and you will not have good results. So it's not a question of the material, it's a question of the non-modular prosthesis. I don't think about Daniel, what is his opinion about that?
Thank you very much again also for the invitation. It's a great honor to be here. I completely agree with Philippe. These are the two main reasons. I just would like to add a bit more of information which we observed. Number one, we did a study looking at the results after 2 years and after 10 years of the same cohort. And what we have seen were terrible X-rays, but most of the patients didn't do as bad as the X-ray looked like. And what they had after 2 years was basically what they had after 10 years. So the observation was that the implant was moving until it reached a point which probably fit the biomechanical requirements. And then it stayed stable, more or less. If you did the revision, I completely confirm what Philippe says. There was no osseointegration. I mean, they virtually popped out. Second remark, which I think is interesting, because I still convinced that pyrocarbon is a very interesting material, especially in terms of the surface quality and the quality of the material itself, that the MCP joint worked better than the PIP. And we didn't find out why, so maybe, or that's just a guess, that the biomechanical movement in the MCP joint as a ball and socket joint has different forces and is less of a problem for the fixation than the quite complex bicondylar joint of the PIP.
It's really great. There's some really interesting insights here from these guys who clearly do a lot of this kind of work. And it's great. I see that there's some questions coming in the chat and the Q&A. Fire up your questions, audience, and we'll come in and discuss those. Jinbo, I'm really interested in what your perspective is here. When it comes to these kind of review articles, what are you looking for? How do you pick a topic? How do you identify authors? And what are you really looking for them to convey? What do you want to read when they send something back into you?
Right. Most of this review article is by invitation. It's not by free submission. What I has been looking for is the experience from a well-established team or the review from a very senior surgeon who has lifelong experience about certain aspect of hand surgery. I think these are very valuable, because if a very well-established surgeon who spend lifelong time to work on several aspects of hand surgery and stick to the conclusion or the practice they prefer, which is very valuable. If you go to somewhere to have fellowship, then these are the things those senior surgeons will teach you. Why we don't publish that in a journal and give the leading position for those people who has contributed to the hand surgery. I think all this invited review reflecting the contribution to hand surgery is worth reading by many people of our profession.
It's really interesting to see this, and these are the kind of insights that I suppose are kind of written versions of the kind of in keynote invited lectures. So that's
right.
It's really
exactly
great.
Right.
May I add a personal observation, because I had the great honor to write such a review article as well. Number one, it is a challenge to write that, because it forces you to bundle your experience in a paper. Number two, it's a very, very nice opportunity to publish things which are probably not completely watertight, but reflects your daily experience. And as Jimbo said, reflects also your experience you accumulated over the years. So I think it's a great way of adding knowledge to the hand surgical community on a different level. So I'm very grateful and happy for that part of the journal, which I think is very, very interesting.
Thank you, Daniel.
And Philippe, what was your experience? How did you find writing this, condensing things, pulling together?
How do you find writing this paper?
Yeah, how hard was it to write?
It was quite hard, but as said Daniel, it was an exercise for me to get some back view of my experience, and to be as more simple as I could to share my experience and the ideas behind the experience I did, and also the conclusion of my experience. You have seen about the PIP, but I have also good or bad experience with other implant. So it was a very nice exercise for me and for my team, and I would like to thank very much Jimbo for asking me to write this paper. It was an honor and a very nice way to spread ideas in the community.
Well, that's great. And I think, you know, it is such a detailed paper. I think we'll go back and dig a little bit more into some of the actual content. I think, Jill, you've got another question. And whilst Jill's asking that, I'm going to have a look at all these questions that are coming up in the Q&A for us.
Jeremy. Yes, I have another question, and I think it comes back to the fact that Philippe's showing us all of his experience and the skill that he's learnt with these implants. During my time as a hand surgeon, I've sat in lots of meetings and I've seen people with the first CMC joint trying interposition arthroplasties and showing results where the implant has subluxed or dislocated. And my experience of seeing these presentations has led me to not try these in my patients, but Philippe has very good outcomes with this. And I want to know, what's his secret? How does he get these good outcomes?
There are no secrets in the results and the technique. The second is in the CMC joint, there are many different implants, and the concept of each implant is different. You can use implant with a stem, which are hemi-arthroplasty. I don't like this implant because there is no osteointegration, as we have said previously, and I prefer the concept of interposition implant. These implants are completely free, so they have to be stabilized. And there are two kinds of implants. Implants which have a convex shape, which are very unstable, so they need to be stabilized with a very meticulous ligamentoplasty. And this is the key of the results of the surgery. If you don't do properly the stabilization with the ligamentoplasty of this kind of implant, you will have an instability, and I get an instability in my experience. But if you look at the paper with bad results, you will see that most of the surgeons did not do properly the stabilization technique. The other kind of implant are big concave implant, which are very much more stable. It's the thin one in the Pyrocarbon, and with this implant there is no necessity to stabilize it because its shape is auto-stabilizing, and also it's a thin implant, so the ligament around the joint are preserved during the surgery and may be preserved during the approach and the surgery. So this is the key and not the secret, but the key of the results on the surgery.
That's really interesting. Thank you, Philippe. And we've got some questions coming up in the Q&A that do relate to this. So Niall McInerney is asking, Philippe, do you perform CMCJ pyrocarbon in the presence of subluxation? In the presence of subluxation. The paper says not to, but do you ever bend the rule?
The paper said not over 1/3 of subluxation. And in my experience, you can do pyrocarbon interposition if you have a slight subluxation of the base of the metacarpal. It's not a contraindication, but as you get more than 1/3, you have to change the off procedure. And if you have people with hyperlaxity of the CMC joint, I recommend not to use interposition implants.
Okay, that's very interesting. And there's another question coming up about pyrocarbon from Philip Matthew, who's saying, why did you move to pyrocarbon for the STT joint? What was your rationale?
There were another pyrocarbon implant, which was called STPI implant, but this implant had to remove the distal pole of the scaphoid. And you know that the scaphoid is the key of the stability and the aids of the carpus. And in my opinion, I prefer to preserve the distal pole of the scaphoid and its ligament, and to use a thinner implant with the pyrocarbon, which is more effective for the biomechanics and the kinematics of the scaphoid. And it preserves the height of the carpus as well.
Excellent. That's, again, really useful to be able to pick into the kind of the detail here. And we've also got a bunch of questions about the PIPJ that we mentioned earlier. So we've got Sue Fullylove, BSSH president. We'll give her a shout out. She's firing up questions for us. And she wants to know what both Philippe and Daniel, what implants are you using now for the PIPJ? And what do your 10-year results look like, please?
I use a modular implant because the key of the PIP arthroplasty is to first get a very nice placement of the axis of rotation. Second, to have a proper tension of the collateral ligament, and only a modular arthroplasty can get these two points. I use personally the Tactus implant, which is a modular implant. I use it since nearly 10 years. I have got good early results. They have been published with 2 years follow-up. I have seen that with this implant, I can use it even if there is a clinodactylia, or even it's a PIP joint of the index finger. But with the follow-up, we see that there are some occurrence of deformity with swan neck deformity, and some kind of loosening. And this is a disappointing view after a long follow-up. And I think the problem of this implant share all the problem of the total prosthesis with a fixation into the bone. And it remains to make some, we have to make some progress in with this implant or other implant.
And Daniel, what are your thoughts? What are you using in PIPJs?
We try to use a differentiated approach depending on the situation of the joints. I think it's important in the radial joints, digit index and middle finger, we prefer a 2-component implant as well, because, and this has been proven, and it also shows the experience that it has much more lateral stability, which is important with pinching with the thumb. So I think the times for really fusing all index PIP joint is over, because we have these implants which provides enough lateral stability also in the long term. In the more ulnar digits, you can think about silicone, but it depends there a bit on the bone situation and on the joint situation. If you have a deviated joint with some defects in the bone, you rather go for a 2-component implant as well, because we could show in our series that with the silicone, you're unable to correct this deformity, at least in the mid and long term. An interesting approach is the replacement of unstable silicone with a Tactus prosthesis. So Philippe's implants, the Tactus, has the possibility, because it's so modular, and it even allows to compensate for more bony defects, to even be a revision implant for failed silicone. So I think there's a differentiated approach according to the individual situation of the patient.
That's brilliant, and that's really great. You've covered also Sally Ann Phillips' question, because she was bringing up a question about silicone for these joints. One of the questions that came up at the start that we haven't really touched upon is, what about the approach? We talked a lot about the actual implants, but for PIPJ, dorsal, volar, what's your preferred approach? Philippe and then Daniel, please.
I prefer a dorsal approach because I am I have more convenient with this this approach. With the dorsal approach, I have learned that reinsertion of the central bond is not necessary. If you open the extensor apparatus like a book and you close it without osseous reinsertion of the central bond, it works very well. So it's my preferred approach, and it's more convenient if I use a total prosthesis with this approach. I have tried, I have used a palmar approach with silicone implant, and I have seen that it's a very nice approach for early rehabilitation. But for total prosthesis, in my experience, I have not get a good experience with it, and I prefer dorsal.
And Daniel?
We just published a paper where we were analyzing the results of different approaches with the same implants in a small team. And we have seen, just to sum it up, that the dorsal approach provided the best range of motion of all the approaches, dorsal tendon splitting, as Philippe just said before. We don't recommend the Belmay approach anymore. We had a lot of complications. The Waller approach has the best flexion, but the least extension. So extension deficits due to scarring of the Waller structures. So our routinely performed approach is the dorsal tendon split, which has, in fact, also a very good advantage to do the PIP implant arthroplasty in local anesthesia in a finger block only. And that's very nice to show the patient on the OR table how good it moves.
That's brilliant. Thank you very much. And I mean, I see there's still more questions, but we're going to move on to our next section. So I'd suggest that we maybe we'll try and answer some of these questions live with the typing. Dig into the review article. There's so much detail in it. I was really astounded at the depth that's condensed into this review article. It's a really good one to read. And thank you all for the questions on this. And we're going to move along to our other paper, flip from the bony side to the soft tissue side, from the orthopedic to the plastic, in our orthoplastic evening. And we're really grateful, as I said, to have Ahmed Sadek from Egypt joining us, and Yazan Al-Ajam, I'm going to invite to present a summary of this study of flexor tendon repair. Thank you, Yazan.
Thank you, Jeremy. Good evening, everyone. I am a plastic surgeon based at Manchester Hand Unit, and I would like to present this Sadek paper on flexor digitorum profundus with or without flexor digitorum superficialis tendon repair in acute zone 2B injuries. The aim of the paper was to compare the repair of the FDP alone versus both FDP and FDS in patients with zone 2B flexor injuries. The introduction starts by defining zone 2B as the zone between the edge of the A2 pulley and insertion of the FDS, according to the TANG classification. And while there's good evidence for repairing FDP alone in zone 2C injuries, that's the narrowest area under the A2 pulley, the same cannot be said regarding zone 2B injuries. So with that, the author carried out a retrospective comparative study examining outcomes between patients undergoing FDP repair alone versus both FDP and FDS in zone 2B. Objectives that were measured were range of motion, both active and passive, functional grading in the form of the TANG score, grip strength, and PIP joint flexion contraction. For the TANG grade, the sum of the active range of movement of both the PIP and DIP joints of the repaired digit is obtained. This is then compared to the contralateral side as a percentage return of motion, and a functional grade is then given. This retrospective study was over a 9-year period at a single unit by a single surgeon. The patients were identified as having acute, sharp injuries to the flexor tendons. Primary data on patient demographics, handedness, the affected digit, type of anesthesia, time to surgery, and operative time were collected. These study inclusion criteria were acute sharp injuries to flexor zone 2B that were repaired within a week, patients that had a complete FDP with a complete or a partial FDS injury. Those had both tendons repaired and those that had only the FDP repaired, and patients over the age of 16. The exclusion criteria were those that had less than 12-month follow-up, those that presented more than a week after their injury, and those with extensive skin, vascular, or osseous injuries, and finally those less than 16 years of age. With regards to the anesthesia, between 2009 and 2015, regional anesthetic in the form of an auxiliary block was used, and towards the latter end of the study, Wallant became the mainstay, with general anesthetic reserved for non-cooperative patients. With regards to the surgical technique, a standard Brunner's incision was used for surgical access. FDP was repaired using a 4-O-proline 6-strand core and a 6-O-proline epitendinous. The FDS was repaired with a modified Kessler suture using a 4-O-proline. And the A2 pulley was vented up to 50% to allow for smooth gliding of the repair. Rehabilitation was carried out by the operating surgeon over a 12-week period. And in addition, patients received both oral as well as topical medications to reduce edema. Outcome measures were in the form of total active range of movement, and that was calculated as the sum of the range of motion of the MCP, PIP, and DIPJs. And this was compared to the contralateral uninjured digit. The total passive range of motion of the digit was also measured at final follow-up. And for the functional outcome, the Tang grading system was used as described previously. Grip strength was measured using a dynamometer, and this was also compared with the contralateral side. A number of statistical analyses was carried out depending on the type of data that was used, with a significance level set at 0.05. In terms of the results, there were 28 digits with FDP only repair and 36 who had both tendons repaired. These patients were predominantly young, mostly in the late 20s and early 30s, with a mixture of males and females, and a mean time to surgery of 7 to 8 hours, and a mean follow-up time of 21 months. The majority of cases had single-digit involvement. There was no statistically significant difference in outcomes between the two groups with regards to the total active range of movement, the total passive range of movement, or the total active range of movement as a percentage measure of the contralateral side. Complication rates were also low. However, grip strength was statistically greater in patients with FDP and FDS repair. Patients with FDP only repair showed significantly greater flexion deformity in comparison to the FDP and the FDS group. And finally, although there was a significant difference in the Tang grading between the two groups, when both good and excellent outcomes were combined, there was no difference. With regards to the single versus multiple digit subgroup analysis, in patients who sustained single digit injury with FDP repair alone, the total active range of movement percentage, grip strength, and grip percentage was significantly better than multiply injured digits. This was also true of the Tang grading, flexion deformity, as well as the operative time. Conversely, among the FDP and the FDS group, patients with multiple digit involvement achieved significantly better total passive range of movement than those with single digit involvement. And those with single digit involvement achieved significantly better grip than those with multiple finger injuries. The Wallant group showed significantly better grip strength and shorter surgical time in the FDP and the FDS groups. So in conclusion, this retrospective study, representing a single surgeon's experience over a 9-year period, found no difference in the total active range of movement, total active range of movement percentage, or the total passive range of movement between the two groups. Moore achieved excellent grade with the FDP only repair. However, better grip strength and less flexion deformity was seen in the FDP and the FDS group. And the Tang score reported by the author were comparable to other published data. Limitations to this paper include a small sample size. However, this really must be viewed in the context of a single surgeon's experience. And finally, patient follow-up as well as rehabilitation were carried out by the author, and that may have resulted in some performance bias. So before I end my presentation and hand you over to the panel for discussion, I'd like to ask the author a question. Mr. Sadek, would you be able to just expand on the use of anti-edema oral and topical medications and the evidence base for it, since we don't routinely use these here in the UK?
Okay, what I want to say first, I'd like to thank the organizing committee for the kind invitation, and I'd like to thank the distinguished panel for this nice invitation, and I hope I could be very illustrative and clear in my answers to the questions raised in this discussion. Second, I'd like to thank Yazan for his nice presentation. And for your question at the start, when I use it to use general or regional anesthesia, most of the time we use tourniquet. So after releasing of the tourniquet, we have edema of the or swelling of the operated digit. So mostly when we ask the patient to do active rehabilitation or active motion immediately after surgery or second day after surgery, we find so much difficulty, and we don't find enough cooperation from the patient. So in my country, we have these types of drugs in national, very large national companies, which combine the topical and oral drugs, which may give fast relief of the edema and the swelling post-operatively. So I used to use these drugs actually more than 10 years ago until now, and they give very good results. So it kind of helped me optimizing my rehabilitation protocol and starting it and initiating it very rapidly after surgery. And that's why we shifted now to Wallant. Actually, when we don't use tourniquet, we don't find this type of swelling immediately after surgery because of the hemostasis that we do intraoperatively, and we don't have this type of bleeding.
Thank you. That's a really interesting perspective, and something I think it's really was great for us to be challenged and consider different approaches from different parts of the world and reflect on how they might add to our practice. So thank you very much for that, Ahmed. And I think Jill, I think you've got some questions about this too, please.
I've got some. Thank you very much for this paper, and thank you for presenting, Yazan. I've got some technical questions for you, Ahmed. The suture that you use, the suture is the pattern is originally described with a looped suture, but you're using it with a single suture, passing it backwards and forwards. So I've got, I suppose it's two prongs to the question. Why not use a looped suture? And also, if you are using a single suture, why use three separate ones and tie 3 knots? Why not do a 6-strand repair with one suture?
Okay, thank you for your question, Jill. Actually, in my place, the loop suture is not frequently found. Okay, it's present and it's found in my country, but in my place, it's not frequently found. So I should ask for it before surgery. And you know, in such cases of tendon surgery, it's kind of an emergency. I will not wait till the sutures be brought to me. Okay, so this is one thing. The second issue, as you know, of course, 6-strand sutures are so robust and so strong construct that give me the opportunity to start the rehabilitation as early as possible. And the Tsuk suture, I like this type of suture, and I can't, by personal modification, did a Tsuk-like suture by using non-looped strand or non-looped suture, okay, going back and forth through the core of the tendon, and I distributed the 6 strands into 3 groups, each group with 2 strands in thirds, in thirds according to the diameter of the tendon. And of course, I do 3 knots on the external or the outer surface of the tendon, because in my personal experience, and I think biomechanically, it gives more strong repair when I use more than 1 knot. Because in using non-threaded, or what I want to say, the Prolene suture the knot is not so strong, you know. It may loosen up with rehabilitation. So if I used more than one knot, it gives me more confidence to do more stronger rehabilitation.
Thank you. And I've got another question. So we're in zone 2, and we've got it's about which bit of the FDS, because you said you excise it. So we've got the FDS is splitting, wrapping around FDP and then decussating at the back. So which part of FDS are you excising?
Actually, when I use the FDP only repair, I resect the FDS tendon at its insertion altogether, so I can provide more smooth gliding of the tendon. Sorry, I cannot hear you.
Sorry, can you hear me now?
Yeah.
Does that cause any problems for the PIP joint if you could take an FDS off at its insertion?
I was expecting in my cases to have hyperextension deformity of the PIP joint, but fortunately I didn't find any case that was complicated by this type of complication, and on the contrary, we have the flexion deformity more pronounced in the FDP only repair group, you know. And I owe this by me to my protocol of rehabilitation, because I did more extensive rehabilitation in the combined repair group. So I believe maybe when I do the FDP repair only repair group, I didn't do that much extensive rehabilitation, and that's why there is more pronounced flexion contracture at the PIP joint.
Aren't you? Sorry. You're doing the rehab yourself.
Yeah, of course. Actually, we have rehabilitation unit in my place, okay, but there is no rehabilitation subspecialty regarding hand surgery. And even when I submitted the paper to the journal, there was a frank question from Jimbo Tang to me: "Are you the only certified hand surgeon in your place?" This was true, because I had previously another three certified hand surgeons, but 2 already are retired. Okay, about 6 years ago, and another one who now is working in another place. You see, so I'm the only certified hand surgeon, and there are we are starting maybe a year ago a kind of conjoint protocol now to co-opt with the rehabilitation program from our colleagues in rehabilitation and physiotherapy.
Really interesting to hear the differences in setups and how we're all working. And Daniel, I mean, you from Zurich, you've some questions about this paper too, I think.
Yeah, thank you very much for this paper, Ahmed. I have questions to Ahmed as well as to Jimbo. We are all facing, when we are having experience with a series of patients, and we would like to analyze them and publish them with the statistics. And in order to get the best out of the data we obtain, I think it's kind of an art to really jiggle around with these numbers and figures. And Ahmed, how did you handle that issue in terms of getting out the best of your stats? And the same question to Jimbo as well. You know, what can the journal do to support the authors in terms of having a statistical ideal analysis and a statistical valuable outcome discussion? I think we are all clinicians. We had some stats somewhere, maybe in the university, maybe even later, but it gets more and more difficult to really do the analysis correctly. There are new biostatistical methods, and I think it's kind of a challenge to find its way in that jungle.
Okay, thank you, Daniel, for your interesting question. And for this study specifically, okay, because I'm working in this hand unit since 2008, I believe, 2007. Each patient I operate, I get his data and filed his data specifically and completely in my own files, because just only 2 years ago, we have this registry system in my place, okay? But all patients I operate, I keep their files by myself, because, you know, for study purposes, for allegation purposes, everything, you know, we are taking our own precautions. This is one issue. So each patient, I have his all data since I operate, and pre-operatively also till the last follow-up. This is one issue. Second issue, and I have operated, and I told Jimbo Tang before that I'm preparing an article on 10 years experience in my center about flexor tendon injury in zone 2, and actually this was his own suggestion to do this, and I had operated with a few of my colleagues more than 289 patients with these injuries, and I have all the data completely, okay? Second, we have, as any specialized center, as we are the university center and tertiary health center, the statistics department that aid us and help us in these types of studies. So before we do the studies, we go to them and make the proper analysis and power ratio and everything. And that's why we do these issues in cooperation with them, you know.
So that's really great, Ahmed. And Jimbo, to bring you in here, because just like this kind of journal club, right, this is an interaction between the author and the journal, the editorial team. And how do you resolve this? How do we share the kind of responsibility for getting the right science out there to help hand surgery? What's your perspective from the journal side as the editor-in-chief?
I think this is a great question, and also a very great concern for me, and also should be a concern for many editors. If I answer in one sentence, I would say we always need to interpret or decide conclusion of any statistic analysis in the context of clinical relevance. That means as a journal editor or review or reader, you always need to interpret the finding, the statistic significance or data difference in the context of the clinic usefulness or clinic significant difference. In many times, we are now using very complex statistics, and the journals stress too much on statistic complexity, or sometimes they try to find a mean to detect statistic significance, even the difference between the mean are so small. But that has no clinical relevance. You may have a good p-value, but does not mean clinical doesn't make any sense. And also, if the sample size is not big enough, it's not randomized study, it could be biased. So as a journal editor, I would say it's very important, he's very experienced in the clinic and know the true meaning or true where is the most important question and what our clinician is facing. The clinic journal is not a statistics journal. We don't need to require the author to be too explicit in statistics. However, you need to have a correct, reasonable statistics, but you should interpret beyond that. So in editor, any article for general hand surgery, I ask a lot of questions to the author, like this tendon paper. I ask a lot of questions, try to dig out those significant beyond the statistics. And also, I also try to ask more questions about what kind of statistics method you are using. So challenge them whether they have been try to just show or try to find a method which can review the significance rather than to plainly present the result. I think this is very important. For any editor, if they don't take care of this point, they may allow author to present or just mislead our reader with p-value. But this is not really important or not important or relevant any time or all the time to our practice. So I very often modify or refine the conclusion of that paper to reflect that. I would also need to add, if the finding is related or directly to the conclusion of that paper, that is more important in statistics in relevant. If it's just a finding, it's a finding, it showed p-value. You don't need to care too much. You will see a lot of this kind of finding, but that's not the main conclusion of this paper. That's only a finding. So you will see, like this paper and many paper we have edited, you'll see for those data leading to the conclusion, that's usually final sentence, we conclude, we pay a lot of attention to the data and also its implicated and also correct use of the statistics and also power. That's all important and intricately related. I think the very experienced clinicians as an editor is so important. So the science, practice, experience, and also the sharp eyes look at the data to see where the data lead to conclusion, which data is just a finding is not really so important. You don't need to dig too much.
I think it's such useful advice because I think, sometimes it's like we live on different planets, right? The clinician doesn't go to the stats world, and the statisticians equally, they crunch numbers, but they don't work in the clinic, so they don't necessarily have that perspective, and it's hitting that middle ground. So it's really interesting to hear that perspective and to hear that coming from the top of the journal too. I think hopefully that's reassuring for potential authors. On that note, bringing this into the clinical world, we can't have a tendon paper here and have Jinbo Tang here and not have some clinical thoughts. So what do you think about FDS, Jinbo? Repair, not repair? What's your perspective about this?
I do not repair FDS in most situations because if it's in the zone 2C, I will not repair. If in the zone 2B, I'll repair sometime. That's because in most of the patients of zone 2B FDS tendon injury, which is mostly partial, the FDS go deeper to the FDP. So in most cases, not completely cut. That's my answer. Right.
And I suppose there's one other question I had, I suppose, here to throw to Ahmed and also to Jinbo and our experts, Jill and Daniel. This is obviously an observational study run over several years, and I know that you talked about change in anesthetic from mainly earlier regional to later Walland, but also presumably your techniques refining. You're developing as a surgeon in that time, right? This is the evolution of a surgeon alongside that. And I was wondering how much you think that's impacted on the results, the good results with Walland. Do you think it's Walland? Do you think it's that you're getting better like we all do? I'll see what Ahmed thinks about that, and also maybe Jinbo and how we handle this learning curve that we all go through.
For me, the experience, of course, as you said, the learning curve is getting better with years. Okay. But I believe in Walland. Okay, so even now I'm working on more than one project using Walland and comparing the Walland, these procedures during Walland versus the other types of anesthesia. And actually, for example, zone 1 injury, okay, FDP avulsion zone 1, and I found the results more impressive in my experience. Okay, and the other issue is when the patient finds himself moving his finger completely intraoperative, this gives him the confidence post-operatively to initiate the rehabilitation with no fear. This is one very important issue for the patient. And I believe Wallant has revolutionized the hand surgery perspective.
That's really interesting. So you think Wallant really does make the difference, as well as accounting for experience. And Jinbo, I mean, how do you approach this with these kind of studies? I know you've written about classifying level of experience of authors or the surgeons. You know, you've published that in the journal, explaining how we should classify whether a study's been performed with very junior surgeons or not. But what about as these kind of longer studies? Is there anything we can be doing to kind of comment on this, of how we've grown as surgeons during the study, or not? Do you look at this?
I really look forward to seeing somebody to analyze the, for example, the failure rate of certain procedure against level of experience. I think this is probably more important for joint arthroplasty in some technique, some procedure which is so dedicated, only experienced surgeon can get good result. For the tendon, I haven't seen as well. It's probably also worthwhile to see something like that.
It's really interesting. Well, we've had an hour. We've had an illuminating hour. We've had lots of thoughts, huge amounts of experience, lots of great questions. So we're going to have to wrap up now, I'm afraid. So thank you again to our hand fellows for their presentations, for summarizing. Thank you again to our experts, to Daniel Heron from Zurich, to Jill Arrowsmith from Derby. Thank you to our authors, Ahmed Sadek and Philippe Bellemere. Thank you to Jinbo Tang, Editor-in-Chief, for graciously joining us to give his perspective. And thank you so much to our committee. And thank you guys for joining. So keep your eyes peeled. Stay on just at the end after the jingle. There's the details for the next event. We'd love to see you there as we're growing. This is the third event. We're looking forward to the fourth one already. So thank you very much and good evening.
Thank you. Good evening.
Thank you. Thank you.
Thank you very much.
Thank you.
Thank you very much.